Today we have a guest lecturer here. So this is Dr. David Hadir from the medical faculty in Hadassah, and he will tell you about Parkinson's disease. And I think he will be happy if you stop if you have any questions or anything like that. So do that if you wish, and enjoy.
Okay, so my name is David. I'm from Hadassah, and I'm a Parkinson's disease specialist. We'll speak about the clinical aspect of Parkinson's, speak a bit about the biology, feel free to stop me to ask questions. We have few videos that don't work yet, so we'll have some methodological break in the middle. Okay, so first I would like to define a few concepts. So Parkinsonism, which is not Parkinson's disease, we'll see what is the difference. Parkinsonism is a syndrome, a combination of signs that include resting tremor, bradykinesia, which is slow movement, rigidity of muscles, and impaired gait and balance. We'll have an example later on. Parkinsonism the cause for Parkinsonism are different. Parkinsonism can be drug-induced. For example, medication, antipsychotic medications that block dopamine cause Parkinsonism. And it can be because of neurodegenerative process. Neurodegenerative process can be either idiopathic Parkinson's disease, which we'll speak to on idiopathic Parkinson's disease, or it may be to the other neurodegenerative diseases, which are numerous and we won't speak about today. Whatever the reason, Parkinsonism is due to dopamine deficiency in the striatum. So the syndrome is caused by this biological, chemical deficit in the striatum. And we'll speak today about a single reason for Parkinsonism, which is idiopathic Parkinson's disease, or Parkinson's disease. Now, first, I would like to say a single thing about anatomy. So in Parkinson's disease, there is a neurodegeneration of a group of neurons. It's the dopaminergic neuron in the substantia nigra. Those dopaminergic neurons send axons to the striatum. So they secrete their dopamine in the striatum. So what Parkinsonism is because of lack of dopamine in the striatum that is due to death of a neuron in the substantia nigra pars compacta in the midbrain. Parkinson's disease was first described by James Parkinson. He was an English physician and many other things. In 1817, he described the syndrome. So we'll start with speaking about the clinical issues. Okay, so as we said, Parkinson is mainly a motor disease. So in Parkinson, we have resting tremor. We'll see example very soon. We have slow movement. We have muscle rigidity. We have impaired gait and balance. And what is unique to Parkinson is that the motor symptoms are asymmetrical. People usually start with a single shaking hand, and as the disease advances, still this hand will be more affected than the other hand. Okay, so it's asymmetrical disease, which is one of the mysteries of Parkinson. Any questions? Okay, so now I have to switch to video, so forgive me because it doesn't work from there. Okay, so resting tremor. Sorry. Okay, so sorry, this is, how do you, okay, let's enjoy the music for a minute. Sorry. Okay. Okay, so the tremor in Parkinson is a resting tremor. When the limb is at rest, you see the tremor. Okay? It has a typical frequency of about 4 Hertz. And when the patient is moving, the tremor is vanishing. So you see, the patient is opening his hand, the tremor will vanish. It will come back after half a minute or so, or when he's at rest. This is in different. This is in contrast to other type of tremor. We have in neurology, we have different type of tremor. We have normal tremor. We have the most common tremor, which is an essential tremor. People that usually hold cups or when they are eating, they are shaking. So this is an action tremor, unlike resting tremor. People with Parkinson, at least 80% of them, when they are eating, they don't have tremor. Only when they are walking, when the hand is at rest, you can see the tremor when they are lying with their hand at rest. Okay, the other thing, will be no. Okay, we have a methodological break. Just we'll switch computers. Okay, slowness of movement. When you ask a patient to do a repetitive movement, you see it's very slow. Okay? And okay? Patients are very slow and they are stiff. This is the rigidity. When you check the tone muscle, they are rigid. And they are asymmetrical. This is the second phenomenon we'll speak about later, but you see she's walking abnormally. And when she's walking, her hand she's not tilting her hand. So many patients are the first time their spouse notice Parkinson is when they are walking and one of the hand is stuck. So they are tilting only one hand. And this is the impaired gait. So people are flexed, okay, a bit bended, small steps, and they have fascination. Sometimes they're running after the center of gravity. Okay, you saw the tremor while he's walking, you saw his hand tremor. Now, what is the natural history of Parkinson's disease? So I said that Parkinson's disease is a motor syndrome. You have tremor, you have rigidity, you have bradykinesia, but this is only partially true. It starts mainly with motor symptoms, but as the time passed and the disease advanced, so you start to have symptoms which are not just motor and are not just related to the dopamine deficiency. So you started to have dementia. You started to have gait and balance problems that are not just because of dopamine deficiency. And you start to have bulbar signs. Okay? People have difficulty swallowing and speaking. This is bulbar signs. Okay? This is generally in conclusion regarding the clinical of neurodegenerative disease. Neurodegenerative disease, usually we said that it's a disease that affects a specific population of neurons. In ALS is the motor neuron. In Alzheimer, it's mainly the cholinergic hippocampal neuron more than other neurons. But disease of the nervous system, neurodegenerative, they start more specifically, but then they spread out. If you'll see a patient with Alzheimer in his end of life, you'll see that there is much beyond impaired cognition. Okay, so we said that the disease is start here, and patients are coming because of tremor, and then they have the diagnosis of Parkinson's disease. But actually, the disease probably start many years before, even 20 years before. And we later on explained why we think it's happened, but the disease starts with some premotor symptom in many patients. So what are the premotor symptoms? Depression. If someone is depressed, probably because of reduced catecholamine in the brain, so he had much higher chances of having Parkinson's disease. People with constipation, if you have chronic constipation, so you have 6 times higher chances to have Parkinson's disease later on in life. It's probably the beginning of a process. Impaired smell sensation. People with Parkinson lose their sense of smell sometimes 20 years before they start to have motor symptoms. And they're acting out their dream. People with Parkinson are shouting while they are sleeping. They are running. They are laughing. They are beating their spouses. Many years, sometimes 20 or 30 years before they have Parkinson's disease. Okay, so probably this is some symptoms that are related to Parkinson. Now, I would like to say that all those things are not specific. So, you know, chronic, I won't ask people to raise, whoever has chronic constipation, to raise his hand. But many people have constipation. Many people are shouting during their sleep or night walking or whatever. Many people have impaired smell. There is many reasons for those symptoms, okay? The minority of people, it's probably related to Parkinson and they will develop Parkinson. So if we'll say later on that let's say if the chances of having Parkinson is about 1%, so if someone has chronic constipation, so his chances are 6%. So it's still 94% of people with chronic constipation won't have Parkinson, okay? So don't try to check who is in your surrounding have some of those. Okay, so, yeah, sure.
About the part in the brain which has the damage, what it's responsible for?
In the substantia nigra pars compacta?
Yeah.
Okay.
The one which near the amygdala. Yeah?
Yeah, the one that having a degeneration. Okay, so we know that dopamine is required for fast movement, okay, in the striatum and generally for movement. But we know it from clinical correlation. We don't know how it's exactly doing it. And we know that if, I don't think I will speak about the basal ganglia generally, but the basal ganglia have input structure and output structure. The striatum is an input structure. So we know there is lack of dopamine, so probably there is a wrong output, and there is this bradykinesia, there is all the Parkinsonian syndrome. But if we ablate the output structure, so then people are returning to normal, although they don't have dopamine. So we don't exactly know what is the role of the basal ganglia. I won't go into computational theories, but probably it has something to do with learning and reward system, definitely with reward system, but how reward system is related to learning movement and daily learning of movement.
Okay.
So
it's make the dopamine.
Yes,
Dopamine
so this is. Yeah, in the substantia nigra pars compacta make the dopamine and secrete it to the striatum. What it's exactly doing in the striatum, there are many theories. But we know that if we delete the output structure, so people return to normal, so whatever it's doing, at least partially, it can overcome by other. So it's not maybe a definite answer, but I don't think there is definite answer. Okay, the epidemiology of Parkinson's disease. So you see this is the prevalence of Parkinson's disease. So you'll see that already we have some patients that are around 50, and it increases until about 2% at the 8th decade of life. So overall in the population it's about 1%. Okay, so it's the disease of the elderly, but 10% of patients with Parkinson are under the age of 50. And rarely you can see patients even in their 30s, which usually the genetic forms. Okay, now treatment. What is the treatment? So, as I said, Parkinson is a lack of dopamine in the striatum. And we have the precursor for the dopamine, which is an amino acid, levodopa, L-dopa, that was discovered actually this year is 50 years for the levodopa. Few Nobel Prizes are associated with the discovery of levodopa. And levodopa is the precursor of dopamine. We cannot give dopamine because the dopamine is not crossing the blood-brain barrier. Okay, the blood-brain barrier is a selective barrier that interfere with penetrance of different molecules into the brain. So if you give dopamine, it won't go in. If you give levodopa, the levodopa goes in, and then in the brain, by enzymatic reaction, it turned into dopamine. Okay? Now, levodopa cannot be given alone, because if it will be given alone, it will be turned into dopamine in the peripheral system, in the intestine and outside the brain. And dopamine is causing nausea, it's causing reduced blood pressure. So if you give dopamine, if you give levodopa by itself, you need a huge amount in order for a bit levodopa to go in and turn into dopamine. So this is why you give it with an inhibitor of the enzyme that make dopamine out of levodopa in the periphery. You'll give it with carbidopa or benzorazide or some other molecules, it doesn't really matter. But this enzyme doesn't cross the blood-brain barrier, so it prevents from levodopa to turn into dopamine in the outside the brain, and then all the levodopa goes in. Okay? The carbidopa was discovered a few years after dopamine, and initially they could give after levodopa, sorry, and initially they could give only levodopa. And if you remember the movie with Robin Williams, Awakening, someone saw it? So he was in the pre-carbidopa area, and he had to give a huge amount of levodopa so it will start working, and usually patient had side effect even because before they had a higher dose of levodopa, high enough dose of dopamine in the brain. Now, there are other treatments, but this is the gold standard. This is the best treatment. We lack dopamine in the striatum. You can replace dopamine by giving levodopa. Okay? We have some other group of medication that works. We can give dopamine agonists, which imitate dopa. It's not dopamine, but imitate dopamine. Sorry, but those are less efficient, and this is definitely the gold standard. So one of the definitions of Parkinson is that patients respond well to levodopa. If you made the diagnosis of Parkinson's, it's correct diagnosis, so patient will respond well. So here you can see an off phase, a phase when the level of levodopa is low, and the patient is very Parkinsonian, he's very walking slow. You can see tremor of his hand. Okay, he's slow, he's not moving his hand. Okay, so everything is very slow. He's a bit banded. It's hard for him to turn. You need many steps in order to turn. He has difficulty initiating walking. All those are part of the bradykinesia. And this is after half an hour or an hour after he takes his levodopa. So he looks normal. Yeah, he's a bit bent, it's true. Yeah, maybe he doesn't have enough dose, but yeah, if you would see him in the street, probably he's not bended than other people in his age, including some people in younger. Okay, now, initially we give levodopa and everything is perfect. Okay, this is called the honeymoon phase. So, the definition is this: I can do this. When the patient are off, okay, and on, it's like a switch, electrical switch, and it can switch in a minute. Okay, you can see sometimes patient sitting in front of you. He took his levodopa. He's speaking. He's very slow, and then in a 2 seconds, you see after 20 minutes, there is a second when you see a spark, and then you have a normal patient in front of you, because there is a threshold between the on or off, and it's a one or none threshold. Okay? So initially, you give the levodopa, let's say 3 times a day, and because there is a half-life, a long half-life for the medication, which we won't speak about the half-life, the physiological half-life is longer than the blood half-life. So you always keep the patient on, okay? You can give him the right dose and he will be always on, Okay, he starts to be off. You know that you have to take his levodopa again. You gave him the levodopa 3 times a day, and he's never off. Okay?
Sorry, could you repeat that? Why
Yeah.
we don't want him to be on the off mode?
It's not that we don't want him. He just feels uncomfortable. He's rigid. He tends to fall. So you want to keep him.
Right before he goes into the off mode, you typically give him more.
Yes, yes. So so you give him 3 times a day, and usually it's enough. So he will never be off. And actually, it's even more complex because if you forget 1 or 2 doses or 3 days doesn't take his medication, he's still on, because the brain half-life of the medication is very long. Okay, even few weeks. Okay. But then after a while, and this is years, things are becoming more complex. Okay. So then you give the medication, and he's going to a hyperdose. The dose is increasing steeply. And then he becomes dyskinetic. He becomes hyperkinetic. He was bradykinetic. Brady is slow. And then he becomes hyperkinetic, moving too fast. Okay? And then it goes down, and then he moves, he's well controlled, he's in a good on, he's moving fine. And then he's off. Okay? And then you have to give another dose, and it's moving between those three situations, and you can't find the proper dose to keep him in those limits. Why does it happen? So the answer is probably complex, but probably the more important issue is that the diseases advance. Okay, the disease advanced. So, in the beginning, you gave the medication, and there are enough substantia nigra pars compacta neuron, there are enough neurons that can uptake the medication, keep it, and release it gradually. Okay? But as the disease progresses, he has less and less neurons that produce dopamine according to the physiological signal, and there are more neurons that take the dopamine but produce the dopamine without any control. Okay, non-dopaminergic neuron, probably the serotonergic neuron, and then the dynamic becomes very close to the half-life of the medication in the blood, which is about 1.5 hours. Okay, so then it cycles of 1.5 hours or 2 hours of off, a bit on, dyskinesia, a bit on, off. Okay, so patient having those what's called motor fluctuation. So I want to show you patient in the dyskinetic range. Okay, so you see any movement she's doing producing other movements. Okay, and when patients are speaking, this is Michael J. Fox, of course, it's some interview, is moving, okay, is excessively moving. And okay, this was a short video, I'll play it again. Okay, those are moderate dyskinetic patients. Sometimes the dyskinesia can be very violent, sometimes very subtle. Okay? Now, patients prefer to be in the dyskinetic mode. Okay? The dyskinetic mode in many aspects doesn't interfere the patient unless it's very severe. Usually the family is complaining about the dyskinetic. But patient in the beginning even doesn't know that they are moving so much. And patients prefer to keep themselves hyperdosed to be in the dyskinetic mode and not to be on the off mode, which is very unpleasant. Yes.
You said that a lot of times the effects can remain several hours, even to several weeks, even after
Yes.
the person doesn't take. Why then do you give the dose 3 times a day? It wouldn't be better
Yes.
for the person if one dose affects them for 2 weeks, and it would be better to give them a dose once every 2 weeks?
Yeah, so this is a good question. There is some idea which is not proven that the level in the blood has to be as stable as it can. So usually, theoretically, I would be happy to give a patient every 1 hour a small dose, theoretically. Okay? There was a concept that maybe this is delaying the appearance of the dyskinesia, of the motor fluctuation. Okay? But generally, if you give a patient the full dose at night, he will still feel the same. Theoretically, you know, there are in medicine there are traditions that are the result of some philosophical or biological thought that might not be true, but we still stick to this practice. Okay, but it's true that if a patient saying after each medication I'm very dizzy and sleepy, so I'll tell him, okay, take all the dose at night and go to sleep, and usually it has a good effect. So it's a good question. Now, okay, so look at this broken line. So this is the fluctuation a patient have when he's switching between the on and off. Okay, the measure here on the Y is they ask him to tap. Okay, so if he's bradykinetic, if he's off, he's tapping slow, and if he's fast, he's tapping fast. Okay, so you see, you have motor fluctuation about every, I don't know, 2 to 4 hours. He has on and off. Okay, so what are the solutions here? So one of the solutions, and Jerusalem is actually a very big center in both developing and applying this solution, is deep brain stimulation. Okay, so you put 2 electrodes that send current to the basal ganglia of patient with Parkinson, specifically to a nucleus called subthalamic nucleus or globus pallidus interna. It depends. So there is those 2 electrodes which you insert in neurosurgical procedure, and there is a cable which goes under the patient's skin. Okay. And it's go to a pacemaker, which is usually implanted up under his skin in the chest. So the patient is, you can see some bulb, but otherwise it's not visible. This is a patient with this device, which is called deep brain stimulation. And you stimulate those areas, okay? And stimulating those areas there are many theories, but it still doesn't clear how it works. It's like giving an electronic dopamine. It doesn't cause secretion of dopamine. It's work in some other methodology, some other mechanism, but it's still as if you give continuous therapy. And then you can see the black line. So instead of a very fluctuating patient, you make the patient less fluctuating. Okay, and if it's very successful, it can just be on the on state all the time. Okay, as if you give continuous levodopa. Yes.
Is that normal, the height of the taps?
So if this is what?
Is it normal, the time of the taps in the...
Yeah, so actually here it looks as if it was better than here, you know, this group, but actually here when they test it, it doesn't give you a better control than levodopa by itself. So this is not significant. Okay, those peaks, the difference here. Okay, so it gives you result as a good control with levodopa, but just continuous results. Okay, we have other. So this is a solution for fluctuating patient. Okay, this solution help probably not better or not significantly better than what a good control with levodopa gives, but it's just give it for the entire day and not just for fraction fraction of hours. Okay? Now we have other solutions. We have now, we want to give the DOPA continuously. So sometime for certain patients, it's possible to do a small hole to the stomach and give it directly to the stomach. And then you can infuse it with a gel continuously. And there are some other solutions, okay, which we won't speak about, other advanced solutions. But this is one of the solutions. The problem with this procedure that if you are entering the procedure with certain dementia, so we'll probably will go out of the procedure with a higher degree of dementia. Okay, so it's good for patients where motor fluctuations and no dementia, or not clinically significant dementia at least. Any questions? Okay, so now I would like to speak about a few other issues in Parkinson. Okay, and those will be more, we'll leave the clinic or we'll speak mainly about the background and less about the clinic. So we said that in Parkinson disease there is a degeneration of a group of neurons named substantia nigra pars compacta, which are neurons that produce dopamine, and they are in the midbrain, in the substantia nigra. Okay? Why is it called substantia nigra? Nigra is black, and this is when you cut a brain of a healthy person, you see those two black lines. Okay? And those are the substantia nigra, and those are the dopaminergic neuron. Okay? In the process, melanin is produced. Melanin is a pigment, so you can see those group of neurons. Now, if you look at the brain of Parkinson's disease, you won't see those black lines, okay? Because those were degenerated.
That size, it looks lighter. It's lighter, has less.
No, yeah, I wouldn't say it's a different person. You cannot take a person's brain twice. Okay, so it's a different person. There's in Parkinson's disease, there's no general degeneration of the midbrain, but mainly of those small nuclei. Okay. Okay, so here you can see you see many neurons here. This is a normal patient, and here almost no neuron. Okay, those are the neurons. Now the surviving neurons have those inclusion bodies. Okay, which are called Levy bodies. Okay, Levy was a German Jew physician who described those inclusion initially. It's intracellular inclusion bodies, and the main content of those inclusion bodies are alpha synuclein. Okay. Now, how those Levy bodies are spread. So this is a work. This is today the common concept. Okay, it's called the Braque staging. It's not undebatable assumption, because it was this. You had to do some extrapolation in order to build this graph, but I will explain what is at least today the common thought. So the assumption is that the Lewy bodies start to accumulate and there start to be neurodegeneration in lower part of the brainstem, okay, in the medulla. Okay. Later on, this is called stage 1. Later on, the Lewy bodies spread to upper parts. This is on the second stage, and only on the third and fourth stage they reach the substantia nigra pars compacta. Okay, so only here I see the motor symptom. Okay, so maybe it starts 20 years before you see the symptoms, and here there are some catecholamine areas and areas that shut your motor activities while you're sleeping, and maybe this is why we see the premotor symptoms, but then only when it's reached on a later stage to substantia nigra pars compacta and kill the dopaminergic cells, you see the motor symptoms. Okay? And later on, it spread to the cortex. And this is when you see dementia and symptoms which are not responsive to levodopa, because this is now not just a problem of dopamine, but it's a general neurodegenerative disease. Okay? Now, this assumption, of course, again, you can take whenever you have postmortem you can do once. Okay? People are not dying twice. Maybe in Jerusalem it's different, but generally not. And so in order to build this graph, you have to, those researchers have to extrapolate from post-mortem of young people that die in some car accident, and they had Lewy bodies on the lower part of the brain. Okay? But it's not clear if those people, if they would stay alive, actually develop Parkinson. Okay? So you have to extrapolate. Okay? If you do a post-mortem to someone who is in his early Parkinson, you see that all those areas are affected. You're doing a post-mortem to someone with severe Parkinson, you can see that all those areas are affected. You do a post-mortem to someone without Parkinson, you see that either those two areas are affected, one area are affected, or none of the areas are affected. So this needs some extrapolation, requires some extrapolation. Okay, so as we said, maybe, and this is today the common assumption, that the Braak staging theory is related to those symptoms. Okay, this is, the disease starts here, okay, the clinical disease, but it's exists 20 years, but it was just in lower part of the brain. Yes?
Were the Lewy bodies found in people with other neurodegenerative diseases or only Parkinson's?
Yes, so first you can find Lewy bodies in healthy person, but then you're not sure if they had some subclinical Parkinson's disease or not. And in essential tremor, which is an action tremor, there is a debate if there are Lewy bodies. So generally, you know, almost every, I think, neurodegenerative disease, it has some common inclusion bodies you can find. So you have accumulation of tau in Alzheimer, you have Parkinson, you have today TDP43, which is some other inclusion body. In ALS, there is probably some type of inclusion bodies.
My question is if the young people whose brains they look at could have developed any disease, not necessarily Parkinson's.
No, so Lewy bodies are associated with Parkinson. Yeah. But you know, some people you do a postmortem to someone who is 90 years old, he has some Lewy body, but no Parkinson's disease, at least when you're going back to history, to videos, no Parkinson's disease. So it doesn't mean that we will develop any disease at all. Okay, now the etiology. So for the majority of patients, there is we find no clear etiology for Parkinson's disease. The majority of patients are patients without family history. They weren't exposed to anything. They just come with Parkinson's. They ask, but why? And we lift our shoulders and we say we don't know.
Etiology is like the history of the disease in the family?
Yeah, so we'll speak about the genetic aspect. We know that probably living in a rural living area is a risk factor for Parkinson's disease. And because of some lab work, they think that maybe it's because of pesticides, okay? And we know that people that are exposed to organic solvents, like smelling air conditioning gas, increase the risk for Parkinson's disease, okay? But again, this is referred to a very low percentage of the population. Okay, but as other diseases, this is generally, not just in neurology, but definitely as other neurodegenerative disease, the genetic component is over the time revealing itself. And this is the first gene that discovered to be related to Parkinson's disease. This is a family tree. You see this is female, this is male. All the black are affected individuals. Okay. And this is a family from the Midwest in the States. And they had a mutation in the alpha-synuclein gene. Okay? So actually, this is the first time when people look at family trees, isolated the gene, and then they went to the Lewy body, and they saw that the Lewy body indeed contain alpha-synuclein. Okay? It was not that they know that alpha-synuclein is involved. This is how they discovered the alpha-synuclein. Okay? So this is an autosomal dominant disease, this form. So there are many people in the family. Usually they have a young onset Parkinson. It starts in their 30s, in their 40s. Okay? So this is not the common condition. Today, so this gene was named PARK1. Okay? During the year, more and more genes were discovered. And today there are more than 20 genes for Parkinson, okay, named PARK1, PARK2, PARK3, PARK4. Some of the genes are autosomal dominant. Some of the genes are autosomal recessive. Some of the genes are maternally inherited. Some of the genes cause young onset Parkinson. Some of the genes cause Parkinson which cannot be distinguished from idiopathic disease without any obvious reason. There are two genes that are relevant to the Ashkenazi Jewish population. Okay, one is called LARC2, and one is called GBA. Okay, LARC2 is a gene that is common among Ashkenazi Jews. It's common also among the barbaric population in the Atlas, and it is causing an autosomal dominant disease. Okay, which usually start close to the age of idiopathic disease. So people in their 60s, 70s. Okay, maybe 1 or 2 years earlier, but it's generally a later onset type of Parkinson's disease. Those who inherit the gene, okay, and if one of your parents carry the gene, you have 50% of inheriting the genes, won't have a full penetrance of the gene. So even if you carry the gene, probably, there is a debate about the numbers, but probably you have chance to develop Parkinson in 30, 40, 50%, okay, of chances of developing Parkinson. Okay, maybe if you will live until the age of 120, so the percentage is much higher. Okay, so this is one gene. The other gene is the GBA, the Gaucher gene. This is a gene that causing a Gaucher disease. Gaucher disease is a disease of beta glucocerebrosidase. This is the enzyme that there is a deficit, and there is an accumulation of substance in the liver, in the spleen. Okay, this is Gaucher. Gaucher is autosomal recessive disease. You need the gene from two parents, from both of your parents, in order to have Gaucher. But in relation to Parkinson, GBA is acting like an autosomal dominant gene. So you need only one gene. Okay? Now the penetrance of the GBA gene is very low. So if you carry the GBA gene, and the GBA gene is common in the Ashkenazi population in Israel, so your chances of having Parkinson's disease is about 2 times or 3 times more than the average. Okay? So if the average is around 1%, so if you carry this mutation, so your chances of having Parkinson's disease is 2 or 3%. Okay? There are some mutations which are a bit more aggressive, so then it's 5%. But still, the big majority of people who carry this mutation in this gene won't have Parkinson's disease. Okay? So those are the two genes which are relevant to Israel. Now, what are those genes do? So there's still a debate what they are doing. Some of the genes can be linked in some biochemical pathways, others are not. Okay, so there are both mitochondrial genes and affecting the synapse. Okay, but this is still accumulating knowledge. No one could find the link between all those genes. Okay, what are the numbers? So this statistics is among the Ashkenazi Jewish population in Israel. Okay, the group in Tel Aviv is a very strong group in this aspect. Okay, so there is a big contribution of this group. So you'll see that if you look at people, Ashkenazi Jewish people with Parkinson, so 20%, close to 20% of them carry the GBA gene. And the LARC2 is close to 10%. Okay? So about 30% of the Ashkenazi Jewish in Israel or around with Parkinson's disease have some genetic component to the disease. Questions? Now, we said about risk factor, genetic risk factor, maybe environmental risk factor. We know that people who drink coffee and people who smoke has much less chance of developing Parkinson. Okay? And this is after it's corrected to the age for other diseases. So it's not because they are dying younger. They are dying younger, at least people who smoke, not people who drink coffee, dying younger. But this is after it's corrected to the age and everything. And also we know that probably people who are doing sport has less Parkinson's disease. Now, what is the reason and what is the cause? It's not clear. If you don't know what is your knowledge in reward system, but generally our addiction are dopamine dependent. Okay, so maybe some people have less dopamine, so they tend less to they smoke less because they have less tendency for addiction and to coffee, and also to enjoy coffee. To enjoy, you need certain receptors, certain forms of receptor. Maybe people without those receptors have a higher chance of developing Parkinson's. So it doesn't. The fact there is a negative correlation between drinking coffee, smoking, and developing Parkinson doesn't mean that those are protective, but this is just an epidemiological correlation. Okay, so up to now, yes. No, either one. Yeah. Okay, I would like to raise two biological questions that are, this is an open debate and it's related to neurodegenerative disease, so I thought about raising those questions. We need a break, or it's about 15 more minutes, 20 more minutes. We need a break? No. Okay, so today when I see a patient with Parkinson, how do I make the diagnosis? So I make the diagnosis by when I'm seeing the motor clinical syndrome, okay? I sometimes give levodopa when it's needed, and I see that the patient improves. So probably this is a good strengthening to my opinion. They have the typical clinical syndrome. They have absence of other things. Okay, they don't have peripheral nerve, muscle atrophy, or other things. Okay. So this is how I'm doing the diagnosis. Now there is no. I didn't speak about it. There is a way to see dopamine deficiency with imaging. We are not using this imaging for price. It's not in the Sal Briut for different reasons. But I know, and this is I'm based on a pathological series, that if I'm telling someone he has Parkinson, so 95% he has Parkinson. Okay, so the clinical correlation to the pathology is very good. So we know to diagnose Parkinson very well. Okay, the final diagnosis is you need is with pathology. Okay, so you see in pathology alpha-synuclein, you see Lewy bodies, you see dopamine neuronal loss, and then you can say about the diagnosis, this is definite. This is possible or probable, and this is definite. And if the typical pathology is not found, so you missed it while the patient was still alive. But on the last few years, they discovered at least one gene, probably more than one gene, that turned this equation a bit. So they found that people who carry the gene for Parkin, and probably some of the genes, some of the people who carry the genes for LRRK2 doesn't have Lewy bodies. Okay, those are a series. You see, one autopsy, two autopsies, small autopsies. Small. It's not a series; it's single autopsies. But in those patients who carry the gene had Parkinson, surprisingly, they couldn't find Lewy bodies. In some of them they did, in some of them they didn't. Okay, so maybe all our concept about what is Parkinson's disease has changed. So it's time to change the definition. Until a few years ago, until we had the genetic form, so it was clear. You see the syndrome, you know what will be in the pathology. But now it's a bit different. So what is the role of alpha-synuclein if in the end you don't see the alpha-synuclein? Okay? So again, this is the question: is Parkinson a single disease, or is it a syndrome that we're taking care actually in many diseases? In the future we might distinguish different type of Parkinson disease. Okay, the other question is Parkinson a prion disease? Did you learn about prion disease? Okay, so let me first say a few things about prion disease. So prion disease, this is also a Nobel Prize. Prion disease, it's the most common, the most known example is the mad cow disease. Okay, in the mad cow disease, or in the human form, there are a few human forms, but Creutzfeldt-Jakob disease, there is a prion protein which is normal, and there is a prion protein which is not normal. In the mad cow disease, this is digested from a sick cow. Okay. Now this protein has a tendency. It's the same protein but with different. This is in different conformation, and this protein tends to accumulate and to kill cells. This protein knows, like a zombie, to take normal prion protein and to change their conformation to pathological proteins. Okay, so this is, and then the new pathological protein will also be in contact with other normal protein and will change their conformation. And this is how this abnormal protein is accumulating, and then we have the disease. Okay, we have some amyloid plaque in the disease. Okay, some inclusion bodies in the disease. Now, so this is a prion disease. The Nobel Prize, it's actually a new form of life. Okay, it's some protein that without any nuclear acid, no DNA, no RNA, just take other protein, and this is how it's accumulate and reproducing itself endlessly. So this is why it was Nobel Prize. And nobody linked this to Parkinson's disease. Now I'll tell you about some other experiment. So about 20 years ago, mainly in Sweden, a patient with Parkinson's disease had a transplantation of embryo cells. So they took embryo neurons, substantia nigra pars compacta neuron. They inject the neuron into the striatum. and they expected the neuron to produce dopamine. Okay? The neuron indeed produced dopamine. It was not so successful because you couldn't control the amount of dopamine that those neurons will produce. So patient had a lot of dyskinesia which you couldn't control. In a normal patient, we just give him a break from the levodopa, and then the dyskinesia vanished. Here you cannot control those. And those patients died after 20 years, okay? After 15 years, 20 years. And then they did autopsy to their brain, and they searched what happened to those embryonic neuronal cells, which were at that time about 20 years old, okay? They was from embryo. They have different genetic background from the host. So you have two populations of neurons in the brain. One is patients who are 70 years old. One is a population of 20 years old, different genetic background. And what was surprising, they found those neurons. They had a way to mark them, okay? They found those neurons, and some of those neurons contain Lewy bodies, okay? This was very unexpected because Lewy bodies were not supposed to be accumulated in those neurons. And then there was the theory that maybe Parkinson's disease is somehow slow prion disease. Okay, mad cow disease is a very aggressive disease, or Creutzfeldt-Jakob people get the disease at a certain age and died within months. Okay, a very aggressive neurodegenerative disease within months. But here they said maybe it's a slow prion disease. So healthy neuron are getting infected by the sick neuron. Okay. So and those were dopaminergic neuron. So what was the assumption? Like the prion disease, so this is just let's switch the prion protein with alpha-synuclein. So you have normal alpha-synuclein, you have pathological alpha-synuclein. The pathological alpha-synuclein switch, make the misfold the normal alpha-synuclein. And then this is also abnormal. This is endless cycle. Alpha-synuclein is accumulating, and you have Lewy bodies. Okay. So now we said this is the normal cell. We put them in a sick environment, and now this is what happened. They were infected. Okay. So this is now a big debate. I'll say that there are debatable works whether Parkinson's disease it is really infectious disease, okay? And this is one of the works. I could bring others. You see that this debate is quite fresh debate. So here they took Lewy bodies from people with Parkinson's disease, and they injected into mice striatum, okay? And you can see this is how many neuronal substantia nigra pars compacta dopaminergic cells of the rats. What are the numbers? And after 4 weeks of the injection, he had the close to normal number. Okay, and then after 4 months, some of his substantia nigra pars compacta neuron died, and then continued to die. Okay, this is actually fibers, not the neuron, sorry. Okay, so there was a neurodegeneration, and other works show that there was accumulation of alpha-synuclein. Okay? The problem is that what is the relation between those artificial procedures to the idiopathic spontaneous disease is not clear, and so it's still an open debate. Sorry?
Can you repeat the last sentence? Why is it debatable?
Because you take alpha-synuclein. Usually, in order to extract it, you do some biochemical processes. So, what is the relevant to the spontaneous disease? It's not clear yet. Initially, there wasn't any degeneration, just accumulation of alpha-synuclein. So not all the cycles are closed. Also in parentheses, not all the cycles are closed. Okay, so I would like to, I will finish in 10 minutes. I would like to speak now about a few more clinical aspects of Parkinson's disease. And the main thing I want to speak about is freezing of gait. Okay, so Parkinson's disease, we said they are more flex. They tend to flex their hands, and they tend to walk with slow steps. But some of the aspects of this gait problem are sensory driven. So Parkinson's disease tend to have at a more advanced stage of the disease freezing episodes. Freezing episodes is usually either when they are start walking, so they stand and they have freezing, they are glued to the floor, they try to walk but they can't, and then they start to walk and then they can walk normally. Okay? It's also happen when they are passing through narrow doors. Okay? So imagine this is a door, so they are walking, and then in front of the door, they are stuck. They're freezing. They stuck to the place, okay, with small steps or even totally glued. And only after a while, they start walking. Okay, it's happening when they are turning around. So they can walk normally, but initially freezing is when they try to walk around. Okay, and this is a risk for falls. Okay. Now, what is amazing in freezing is that they can be reduced with visual or sensory cues. Okay, so if Parkinson's disease, and you saw it in a video before, if Parkinson's disease have a very tendency to have freezing in small steps, if he'll walk on a black and white strips, it will be easier for him to walk normally. Okay, because there is probably some loop which are sensory motor. Okay. So we'll see. So those are sometimes very confusing. So you'll see a patient. Okay, she's trying to walk. She's glued to the floor. Okay, you ask her to walk. She can't even initiate walking. Okay, if you ask her to step over his leg, she will be able to. She will glue before. She will be glued again. Okay. Okay, here you have other examples. Okay, so this patient tries to walk. He's glued. It's easier for him to initiate steps if he sees some visual cues. Okay, to turn around is even more difficult. You have to switch motor program in order to turn around. Okay, you can see his flexible posture. Okay, and this is how he's riding his bike. So you see, this is a different motor program. Okay, it was a video in Holland. I think it just vanished for 10 minutes. No problems.
So he can ride freely, but when you're walking, you like...
Yeah, he's totally stuck. It's a different motor program. Okay?
That is the same patient as before?
Yes, same one, same medication, nothing has changed. Okay, if you'll see him, he's look totally normal on his bike. So. Okay. I had a patient when I was resident a few years ago here in Mount Scopus. I had a patient who couldn't walk, but she could dance tango freely. And okay, so this is different motor aspects.
Why would she be able to dance tango but not
because it's a different programs. The Parkinson's disease first impaired your walking program, which is probably your walking program is basal ganglia, your dancing program is somewhere else. Okay, which is not totally true, but it's one of the mysteries of Parkinson. Okay, now it's related to paradoxical movement. So paradoxical movement, we said the patients are very bradykinetic. They can hardly move. Sometimes they are on a wheelchair in advanced stage, but they can't, if they have the sensory cue, they can produce a very fast reaction. So I think we also, for those of you who saw it in Awakening in the movie, you'll see an example here. But there are many stories about patients with, not many stories, a few stories, patients in an elderly house who were all on a wheelchair. When there was a fire, they all took their legs and ran. Okay, it was an emergency case. A different motor program in the brain is operating. So we'll see this video. So this is a patient. Okay, quite severe Parkinson. You see tremor even in the legs. He's very slow. He has tremor of his hand because 20% have some action tremor, even when he's holding the cup. Okay, but he's very fast because this is a visual cue. The ball to catch is a visual cue, different motor program.
It's reflexes.
What?
Reflexing.
Yeah, it's not a reflex exactly, but yeah, it's a different motor program. It's not a reflex, it's not automatic. Okay, you see this is how he walks, but if he starts running is better because the running is a different program. Yes, everything is easier. It's a different context. So in the brain, motor programs are stored by context. Okay, so running and catching a ball is different from running, is different from walking. Although maybe the muscle are doing about the same things. So the motor programs are not in the muscle or in the brain, in different areas. Okay, so I'll just say that there are other. Generally finish. I'll just say that there are other way of overcoming freezing. So some of the patients, I didn't brought the movie, but some of the patients, they have a walker and they have a laser, a red laser on the floor. And then instead of walking, they cannot walk, they are stuck. But then they have the laser and they have to know that they have to walk over the laser. So they're walking like this, and it's much easier. Some people have inverted cane. So if a cane is in this shape, okay, so when they are stuck, they are invert the can. So now they have the handle on the floor. They pass over the handle, and then they continue walking. Okay, so it's a interesting disease, strange disease, like many other neurological disease. And I think I finished.